Thank you. Thank you. Welcome to Grand Rounds. Dr. Fairbairn and I and Cameron are here by ourselves. I'm greeting you virtually to those who are on the call. And I guess at the beginning of every presentation, we give a land acknowledgement. So I'd like to acknowledge that we're gathered on the traditional and ancestral unceded territory of the Coast Salish peoples, the Squamish, and Musqueam, and we're grateful for their stewardship in these lands. It's a pleasure to welcome Dr. Fairbairn to Grand Rounds. She and I have known each other for some time. She was chief medical resident here 10 years ago, approximately, but has gone on to a career that she actually started in medical school, an interest in addictions, and has pursued that career and has been very successful. She's now a researcher, which she has always been, a clinician, and holds a directorship in the addictions group. So Dr. Fairbairn is going to speak to us today with the topic that you can see. So I'm looking forward to it. Nadia.
Thank you, Dr. Casson, for the introduction. And I am very pleased to give this presentation today. I so wish there was a contingent in the audience because I think this topic is one ripe for conversation and debate. So for those of you who are calling in, I do invite you to have questions and comments that you offer at the end. I've tried to leave time at the end for that. So I'm going to be speaking today about Canada's toxic drug crisis and responses to it that have emerged largely during the COVID-19 pandemic. The work I'll be sharing with you today was done with a wonderful team of collaborators through the CRISM network, which is the Canadian Research Initiative in Substance Misuse. Oh, I should just mention someone listening in I don't think is muted. I'm glad you're here, but I'll ask you to mute till the end. And so CRISM is a multinodal national collaborative research and knowledge translation network that seeks to improve the system of care for people who use drugs. So I'd like to acknowledge that this work was carried out on the traditional unceded homelands of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh peoples. And I'm grateful for their stewardship of these lands since time immemorial. So here are my disclosures. I have no conflicts of interest to report. So for today's talk, my hope is that you'll take away a good understanding of the current situation as it stands now with the toxic drug crisis and how COVID-19 impacted the crisis and our response to it. One of the major responses that has emerged in Canada has been around provision of pharmaceutical alternatives to the toxic drug supply, often referred to as safe or safer supply. And you'll hear me kind of use that language interchangeably during the talk. I'll review with you what we're talking about when we talk about pharmaceutical alternatives, and I'll share with you findings from work that I have collaborated on to understand and address barriers and facilitators to implementation, sustainability, and scale up of these strategies. I hope to leave a good amount of time for discussion at the end to deepen our understanding of these issues and potential ways forward. So we are living in an unprecedented time when it comes to substance-related harms. These are US data showing overdose deaths involving opioids per 100,000 population by year. The overdose crisis we're currently experiencing it started in 2013 and it's ongoing and coincided with the steep rise in overdose deaths that involved potent synthetic opioids, particularly illegally produced fentanyl. And we've seen a similar trend in BC and across Canada. In April 2016, a significant increase in illicit drug-related emergency events and deaths in British Columbia prompted the provincial health officer to declare a public health emergency. Since that time, deaths due to illicit drug toxicity have continued to increase in BC, with an average of more than 6 illicit drug toxicity deaths per day in 2021. And we're on track this year for similar mortality rates with an announcement forthcoming on this. Illicit drug toxicity is the leading cause of unnatural death in BC, accounting for more deaths than homicides, suicides, motor vehicle incidents, drownings, and fire-related deaths combined. Illicit drug toxicity deaths are second only to cancers in terms of potential years of life lost in our province. And the toxic drug crisis is national, with BC being heavily affected. So I just want to take a collective pause here to acknowledge when presenting these statistics that they do represent individual lives lost. The continued toll of the unintentional drug toxicity deaths have created devastating effects on families, friends, and communities, and these deaths are preventable. So the primary cause of increased deaths is the growing toxicity and unpredictability of the street supply of drugs. For example, fentanyl and its analogs were detected in 85% of illicit drug deaths between August 2017 and July of 2021, with the proportion of samples checked that found extremely high fentanyl concentrations increasing over time. Additionally, benzodiazepines and their analogs have been increasingly detected in the drug supply. The most common benzodiazepine detected through expedited testing was atizolam, which is not a regulated benzo in Canada. It's brought in illicitly, and it was detected in 40% of deaths between July 2020 and July of 2021. And benzodiazepines increase the risk of overdose by depressing the central nervous system and can make reversal of opioid overdoses more complex, as naloxone will not reverse the sedating effects of benzos. Underpinning all of this is the current drug policy framework of prohibition, which is the primary driver of this illegal, unregulated, and toxic drug supply. Despite the ongoing prohibitionary drug policy framework, there is some evidence to suggest that scale-up of harm reduction and treatment responses after declaration of the public health emergency did have an impact on overdose rates. This study reviewed the period between April of 2016, when the public health emergency was declared, and December of 2017. It examined the impact of 3 strategies scaled up across BC: the distribution of naloxone in community through the take-home naloxone program, expansion of overdose prevention services and supervised consumption sites, and increased access to treatments for opioid use disorders such as methadone and buprenorphine. And it found that overdose deaths would have been at least twice as high without emergency harm reduction and treatment responses during this period. Since March 2020, however, corresponding with the start of COVID-19 related restrictions, there was another marked increase in the number of illicit drug toxicity deaths in BC. The COVID-19 pandemic and related prevention measures resulted in all sorts of consequences, including border closures, which affected the illegal drug supply in Canada in several ways, making the unregulated drug supply more unpredictable. Reduced availability and accessibility of substance use services, such as harm reduction and community-based services. Reduced access to safer drug use supplies. Barriers to accessing online and in-person services. Interruptions in regular medical visits and access to opioid agonist treatment. Reduced access to informal supports and peer supports, and increased isolation from job losses, restrictions on social gatherings, and physical distancing. So, although a number of provincial initiatives have been undertaken in an attempt to address the drug toxicity crisis, these initiatives were not sufficient, and this became more pronounced with the emergence of dual overdose and COVID-19 pandemics. Voices calling for approaches that specifically focused on the toxic drug supply were called for, where the first priority would be to stop people from dying. These strategies included a safer drug supply for people who use street drugs, as well as decriminalization of substance use, so that people using illicit drugs may access support and services without the stigma of drug use or fear of arrest. Of note, the federal government did amend the Controlled Drugs and Substances Act to support decriminalization of drugs in BC, and starting at the end of this month, on January 31st, adults will not be subject to criminal charges for the personal possession of small amounts of certain illegal drugs. So I'm going to focus on safer supply initiatives specifically here today. So safer supply refers to non-toxic or contaminated drugs available to people who are at risk of death due to dependence on the illegal drug supply. A safer drug supply on its own will not resolve the public health emergency, but it is urgently needed to reduce the number of people dying at unprecedented numbers. Safer supply is a broad concept that exists on a spectrum from medicalized model treating people with substance use disorder to a non-prescriber public health model that provides safer supply of regulated drugs to people. Safer supply does not mean all risk is eliminated, but it does mean that the risk of a death due to the drug toxicity is greatly reduced. Of note, the Canadian Association of People Who Use Drugs, a national organization of people with lived and living experience, includes the term legal and regulated in their definition of safer supply and extend the goals of safer supply from harm reduction and improved outcomes to include furthering human rights and social justice. So the Controlled Drugs and Substances Act regulates the importation, production, exportation, distribution, and use of scheduled substances. With COVID-19, exemptions were made to the Act to support continued access to medications for opioid use disorder, such as allowing prescribers to verbally initiate or extend prescriptions, allowing pharmacists to extend or transfer prescriptions for treatment of opioid use disorder to avoid discontinuation, as well as allowing medication delivery to patients by pharmacy staff. And as I mentioned earlier, more recently, Health Canada has granted an exemption to the Act to support decriminalization in BC, which comes into effect at the end of this month. For changes relevant to pharmaceutical alternative access, practitioners may only prescribe, sell, or provide a controlled substance to a patient while that patient is under their professional treatment. There's no ability to distribute or transport controlled substances to overdose prevention or supervised consumption sites or outside of a clinical care relationship with a patient. With these changes, in autumn of 2020, the Canadian government endorsed a spectrum of treatment and harm reduction approaches to address the crisis, including prioritizing safer supply as a primary focus to reduce harm and improve health outcomes for people who use drugs. Health Canada's medical model of prescribed pharmaceuticals form the basis of pre-pandemic safer supply services in Canada. Okay, so what are we talking about when we say pharmaceutical alternatives offered through a medicalized model of care? So within the Health Canada framework, this includes interventions such as injectable opioid agonist treatment, I'm going to say OAT for short for opioid agonist treatment, tablet hydromorphone, injectable OAT, and risk mitigation prescribing. Injectable OAT, the top left there, is an evidence-based treatment for opioid use disorder that involves prescribed injectable hydromorphone or diacetylmorphine, also known as pharmaceutical-grade heroin, taken in a healthcare setting and supervised by healthcare providers, typically where access to wraparound health and social services are available. Tablet hydromorphone OAT is a pilot-based intervention where supervised tablet hydromorphone is taken according to client preference, for example, injected or taken orally in a supervised setting with healthcare providers present. Injectable and tablet injectable OAT are considered part of safer supply interventions when the goal is to reduce overdose risks specifically. Safer supply in a medicalized context generally refers to unsupervised take-home doses. So people take the medications outside of the clinical setting and for a wide range of prescribed pharmaceutical medications. Risk mitigation prescribing emerged via the release of COVID-19 risk mitigation interim clinical guidance in BC in March of 2020 for the prescribing of pharmaceutical alternatives to the toxic drug supply. It provided some clinical guidance for physicians and prescribers on how to offer pharmaceutical alternatives with an aim to reduce the risk of deaths due to illicit drug toxicity, as well as to prevent COVID-19 transmission. So terminology varies across the country and depending on the context, with many providers, particularly in BC, using the term risk mitigation to refer primarily to safer supply prescribing in a medicalized model. So with that context in mind, I'm going to focus on some of the work that I've done with CRISM, the Canadian Research Initiative in Substance Misuse. So this initiative started pre-pandemic with a focus on injectable oat and evolved during the COVID-19 pandemic to include safer supply. The purpose of the CRISM Injectable Oat Initiative is to support expanded access to these therapies in Canada through establishing clinical practice guidelines and operation supports, establishment of a community of practice, and implementation science research via national annual environmental scans of services across Canada to understand the barriers and facilitators to implementation and to advise and support successful delivery of injectable oat in Canada. So the environmental scans we did as part of this initiative were done every year from 2018 to 2022. These scans, as I mentioned initially, just focused on injectable oat services over time. When the COVID-19 pandemic began and the increase of safer supply programs were implemented early in the pandemic as a response to it, and because this initiative had already established capacity to do this type of work, we expanded the work to include safer supply initiatives more broadly at the beginning of the pandemic in 2020. So this work involved a team from across Canada and was led in collaboration with my postdoctoral fellow, Dr. Stephanie Glegg. So the purpose of this study was to describe the operational and clinical characteristics of pharmaceutical alternatives across Canada early on in the COVID-19 pandemic, to explain the reasons for the emerging changes in implementation during the pandemic's first wave, and identify barriers and facilitators and potential mitigating strategies in order to propose strategies to support implementation and sustainability and scale up of pharmaceutical alternatives in Canada. Just a little bit about environmental scans. They employ systematic, objective methods to review formal and tacit knowledge efficiently, and their value is increasingly being recognized in healthcare. So the methods involve gray and primary literature searches, as well as surveys and interviews to detect trends, challenges, and successful strategies in other jurisdictions to inform service planning and delivery. Recruitment can use a variety of sources, including web, gray, primary literature, social media, email, and snowball sampling to reach providers. And we've tried to reach providers through multiple ways, including their professional associations or colleges, the health authorities, guideline committees, research and clinical networks, and as well as peer and advocacy groups. So what we did was we did 2 scans in early 2020. We did one on March 1st, and we did another one 2 months later on May 1st. Given that how quickly programming changed during that early phase of the pandemic. It was a mixed method study, so we used cross-sectional surveys as well as qualitative interviews at these 2 time points to examine prescribing practices and services from the provider perspective. So surveys and semi-structured interviews were conducted, and the qualitative interviews were coded using the consolidated framework for implementation research. On this map of Canada, the blue dots represent those services operating at the first time point on March 1st of 2020. And the yellow dots are the new ones that had initiated pharmaceutical alternative services 2 months later as of May 1st. So at the first time point, there were 21 safe supply sites in Canada. And at the second time point, there were 60 new sites identified 2 months later. There were 19 injectable oat and tablet IOT sites that were constant at both time points. In total, we gathered data from 50 participants representing 103 sites across 6 provinces. This included 25 prescribers, so physicians or nurse practitioners, 8 nurses, and 17 clinic managers and coordinators. So this slide shows the number of sites at each time point offering safer supply, stratified by province. BC is the first one there. So the blue is the March 1st time point, and the green is the May 1st time point. As you can see here, there was rapid growth over time, particularly in our province. And pharmaceutical alternatives were offered in a range of settings, ranging from dedicated clinics and addiction treatment centers to overdose prevention sites via outreach, primary care, youth and mental health services. They were offered in shelters, encampments, and home delivery to support isolation for COVID-positive individuals. This highlights the flexibility of pharmaceutical alternative service implementation. In some cases, a prescriber was offering pharmaceutical alternatives as part of their practice without any additional on-site services. And then there were other programs that offered it in the context of wraparound care as part of interprofessional teams. It's important to note that the vast majority, 79% of sites, had no additional funding for their safer supply services. So they took this work on in addition to their current services offered and without any budgetary or additional resources to offer these services. So in terms of what actual substances were reported that were offered, they all offered opioids. So the most commonly offered opioids was hydromorphone tablets, the 8 milligram tablets most commonly, as well as morphine and fentanyl patches. For programs that offer injectable OAT, they all offered liquid hydromorphone, and 2 of the sites also offered medical heroin. Many sites offered additional substances, including benzodiazepines and psychostimulants. So psychostimulants are like medications for ADHD, for example. And some also incorporated access to regulated products such as alcohol and cannabis into their pharmaceutical alternatives programming, again, primarily to support self-isolation for COVID-19. And as you can see here, again, so BC, which is the blue, led the way in terms of new sites offering a range of substances, particularly opioids and psychostimulants were offered early in the pandemic. In terms of how these services changed as a result of COVID-19, many reported changes to patient protocols. So for example, they made changes to their clinic delivery with reduced expectations around urine drug testing, switching people to take-home dosing instead of witness dosing, shorter or faster titration schedules to get onto the therapeutic doses, and transitioning people sometimes to oral options when needed. Program operation changes were also commonly reported, such as reducing new client intakes, increased use of telehealth, adding PPE for staff, as was done in many clinical settings, as well as in some cases increased and in other cases decreased outreach efforts. So I'll move on now to presenting findings from the qualitative data we collected. As I said earlier, these data were initially coded to the theoretically derived constructs of the Consolidated Framework for Implementation Research. So this framework is composed of 5 domains. Those are the 5 different colors there. The intervention itself, the outer setting looking at factors external to the organization, the inner setting looking at organizational factors, individual factors, and factors related to the implementation process itself. You don't need to worry about this slide, but I'll present you with a few examples from each domain. But please note that the recommendations that I'm going to share with you closer to the end of the presentation are informed by the whole data set. And we used a mapping process for identification of barriers and facilitators to implementation. So getting into the findings. So a number of themes emerged regarding factors specific to the intervention of providing pharmaceutical alternatives. This includes lack of or conflicting evidence for the intervention itself, lack of available clinical guidance on how to implement the intervention, complexity of clinical care decisions, costs of the medications offered, and complexity around balancing of the relative risks and advantages within the reality of an unprecedentedly toxic illicit drug supply. So I'm going to share with you some sample quotes from the data we received. So regarding the problem of inadequate evidence for provision of prescription opioids as pharmaceutical alternatives, one participant said, I'm 57 years old. I was from the generation of doctors who, got our wrists slapped. Well, more than that, our licenses threatened for exactly this kind of prescribing 10 years ago, right? And you need to look at history. You need to look at the research that says there's a lot of harm to unabated opiate prescriptions. And that is very good research, well established. Participants articulated distress in trying to balance potential advantages versus concerns regarding the provision of pharmaceutical alternatives as a novel intervention. So they expressed the opportunity for significant impact for individual patients, but they questioned the impact of increased opioid prescribing at a community level. For example, this quote, "How important would you say in your experience safer supply is for clients? Like outrageously important. Like it's everything. I think it's life and death. I think it's also how we show respect and support. I think it's a gateway, not to drugs, but it's a gateway to care and to human love and compassion. And I think that is the barrier that causes a lot of people to become despaired and isolate from healthcare. Participants also spoke about increased complexity in clinical care when adding pharmaceutical alternatives to the range of substance use care services available to patients. So challenges in determining whether a pharmaceutical alternative medication was leading to side effects versus the effects of the illicit substance use itself causing harms were highlighted. So for example, or especially with people who you give stimulant, say for supply, who may be going in and out of psychosis. And my drug could be causing that, but probably not on its own because of all the other things they're mixing it with. But then knowing that when they hit the psychiatry hospital, the first thing they're going to do is say they're being prescribed Dexedrine, and that's the problem, and stop it. So it's a lot of systems issues. And because without evidence and background to fall back on, it's a lot more risky medical legally. And also, just with patients, when you don't have that wealth of experience and data to look at, it's my best decisions. The participants spoke about the constraints of the current policy context, limiting pharmaceutical alternatives to a medical model of care. So the ability of pharmaceutical alternatives to meet client needs, the social pressures faced by providers, and the need to connect with others when embarking on this work. Regarding the policy framework of pharmaceutical alternatives, as one participant said, truly the whole system needs to be demedicalized. That's not happening within our current framework. It has to be federally, of course, but just being a medicalized model is so problematic in so many ways. There's such a power imbalance between physicians and patients, physicians and nurses, and then nurses and patients. And it's just this entire program needs to be peer-led so that it's not us making decisions for people who use drugs. When we don't really know these things, this really needs to be peer-led. And another quote, I feel very uncomfortable with the position these guidelines have put the average addiction doctor in, that we are forced to be a little bit godlike in balancing an individual's needs against societal harms. And I don't like that position. Decriminalize, legalize, and it should not fall onto the shoulders of doctors, nurse practitioners, and nurses to make these hard decisions. So participants spoke about social pressure also not to prescribe in their local environment. One clinician stated, I'm in a very conservative and resistant area and atmosphere when it comes to practice for addictions. I got hate emails from the different addiction medicine providers in my region about my practice and what I was prescribing, and all of these kinds of things. I've had letters of formal complaint and all kinds of issues from them. Participants described feeling unsupported in offering pharmaceutical alternatives from varying sources, particularly lack of network connections. Activists and people working in the community are saying that they're going to be at higher risk of contracting COVID or from toxic drugs or whatever else, which I agree with. And then also being told, be really careful and make good notes, because if there's a death, you may have to defend yourself and you may end up in court. Yeah, the tension of do this, but don't do that. So that was just very, I felt really alone in that. And so my team is kind of supporting, but this is mainly my program, so I just felt really, really alone. Participants spoke about the compelling reasons to offer pharmaceutical alternatives in the face of these challenges in order to meet the immediate needs of their patients. So as one said, I think patients, see it as life-saving. That's usually the biggest feedback that we get in the first few weeks or months of people being initiated on the program. People feel stabilized. They feel like they have their life back. They feel like they have time in their day back. They're able to pursue other things like housing or kind of gaps in their own medical care that they haven't been able to achieve because they've been seeking and using drugs day in and day out for so long. And participants spoke about the organizational factors that impacted delivery of pharmaceutical alternatives, including a culture shift in addiction medicine care settings that have often been based on punitive care approaches, and to reimagine what's possible in therapeutic relationships with clients. So here's a sample quote. There's sort of a de-education that needs to happen. People have had so much access to traditionally really punitive structures in addictions care that getting people to expand their imagination and their ideas of what's possible in a relationship with somebody who's helping them with their addictions and their substance use is a big part of it. A lot of people still feel that it's okay to have punitive responses to dirty urines, so it's interesting to watch people rethink what's possible with care. And participants spoke about balancing factors that might deter offering pharmaceutical alternatives, especially concerns regarding disciplinary action from the governing colleges, with experience caring for patients and appreciation of how pharmaceutical alternatives could make a difference at the individual patient level in particular. Participants spoke to the importance of strength in numbers to reduce fears of disciplinary action. And they spoke about the role of the implementation process for pharmaceutical alternatives during this early phase of the pandemic. So one of the barriers identified was around challenges engaging physicians in particular to prescribe pharmaceutical alternatives. Here's a quote. "I think this runs directly against a lot of the current advice being given to physicians. I think that's why you're going to see nurse practitioners adopting this faster than physicians will. We don't have the same history and baggage I think that medicine comes with from the sort of the bad old days of awful prescribing practices. I think it sort of polluted them against the notion of prescribing in these quantities." So taken together, recommendations that emerged from this research included providers' desire for a true safer supply, one where the regulatory policy framework changes to decriminalize or legalize drugs, and where prescribers are removed from being the gatekeepers of access to safer supply, where pharmaceutical alternatives are available outside of healthcare settings, and where people with lived and living experience are engaged to inform implementation of safer supply. Within a medical model, there are a number of strategies that can inform directions for provision of pharmaceutical alternatives. So in the policy regulatory environment, access to additional medication options such as diacetylmorphine, liquid hydromorphone, inhaled options, expanded drug coverage for these medications, and optimized funding to support multi-site planning, sustainability, and scale-up could address some of the barriers identified. Gathering evidence to evaluate both individual and also the societal impacts of this intervention were strongly called for. Support for national guidelines updated to incorporate current evidence and trends that is college endorsed, as well as education and training and community of practice opportunities may facilitate uptake among prescribers as well. So thank you for your time and attention today. Just to go back to the objectives, I hope you came away with a good understanding of the current drug toxicity crisis in Canada, the impact of COVID-19 on the crisis, and where we are at in terms of pharmaceutical alternatives as an element of the response. I've included references here for the research articles that were published based on this data, and I'd love to invite questions or reflections from the audience on this really crucial topic at this time. Thank you. Sure. Is there anybody online who'd like to make a comment or ask a question?
You didn't talk about prevention.
Pardon me?
You didn't talk about prevention.
Yeah. Do you want to expand on that? What you were thinking when you heard my talk in terms of prevention?
I didn't hear anything about preventing anyone from using, discouraging people from using in the first place.
Yeah. And I would imagine that you would feel that that's really important in terms of thinking about downstream impacts on reducing future overdose death rates. So I would recognize that prevention is one of the key pillars when it comes to strategies to address substance use and consequences of substance use. And there's lots of ways we can implement preventive strategies, both within the healthcare system and outside of the healthcare system, such as in schools and with youth. It wasn't an explicit focus of the talk today, primarily because as a way of urgently addressing the toxic drug crisis, it will likely take time for prevention measures to have major impacts. So it's less discussed in the context of a public health crisis, but it's absolutely important to think about it in terms of the big picture and prevention of all these harms we're talking about today. Yeah.
So usually when we look at studies, we look at population. So the addiction population are homogeneous or not homogeneous? Has anybody looked at who the population is, not just what they get, but so how many people have different mental health disorders, how many people have consequential disorders or consequential disorders? Can you give us an understanding of that and maybe your research? This research doesn't touch on that.
Yeah, I mean, I think any of these questions we're touching on, like what a complex issue substance use is when we're thinking about the social and medical implications of substance use and substance use disorders. It's important, I think, also to recognize that there's a whole population of people who use substance use who aren't necessarily experiencing consequences of use. So we're focusing on folks who are experiencing consequences of use by way of addiction or substance use disorder. In terms of the Canadian population and what we're seeing, I actually don't know if we have very good national data around what characteristics define folks, for example, with opioid use disorder in Canada. Certainly, at St. Paul's Hospital, I can speak more to it in terms of our local context. I think here locally we see a high representation of people with sociostructural vulnerabilities, poverty, et cetera, and high burden of comorbid mental health issues. I don't think that's necessarily representative of the broader Canadian population. And certainly there's key differences when we're thinking about urban versus rural settings, where things like access to care and health services become highly relevant in the rural setting. When it comes to overdose deaths, the data is quite clear that what people are dying from is contaminated, purchased, unregulated drugs. So our story is a little bit different than the US story. The US story is one where there was a prescription opioid epidemic, and then there was rapid deprescribing when they realized all the harms of high prescription opioid prescribing, with unintended consequences of that, with people transitioning over to illicit or illegal drugs and experiencing the toxic drug supply that way. We have less of that story here in Canada. So less folks where there was excessive prescribing of prescription opioids, deprescribing, and transition to the illicit drug supply. Often people initiate opioid use via the illicit drug supply in a Canadian setting. I'm speaking in generalities, of course. But that is more of a US historical state where prescription opioid prescribing, excessive prescribing was really, really problematic, as were the unintended consequences of rapid deprescribing. So what happened in terms of initiating the drug crisis and the call for the public health crisis in 2016 was really around people who were already using unregulated drugs, and all of a sudden fentanyl started showing up with increasing concentrations over time, with increasing other contaminants over time, particularly benzodiazepines, which is more recent during the pandemic, and the variability in what's actually in a particular drug sample. So it could be 2% fentanyl one time and 90% fentanyl the next time, and an inability to kind of prevent overdose given that unpredictability of the drug supply.
So follow-up question, but not related to the first, but is there any other strategies that are considered for those people that have overdosed and actually appear at either, I suppose, at a hospital, but it could be, is there any other strategies that
Yeah, are there any that you've heard talked about at the hospital?
Well, there are. I mean, that,
Yeah.
So I know that. Sorry, I have an understanding of what's going to be happening, and maybe I should be more direct. On the question. Is there the ability for someone who has overdosed and say that twice in a day? Is there ability to continue to manage that person in an inpatient setting or an outpatient setting supervised as mandatory? Is that being talked about?
Yeah, so I think you're talking about the limitations or potential extension of the Mental Health Act in the setting of opioid use disorder and immediate harms related to overdose there. I think that's probably one of the most fraught topics in psychiatry and substance use care. And as you know, Dr. Casson, my training background is not psychiatry. And so I do defer to their expertise when it comes to talking about the implications for changes to the Mental Health Act when it comes to substance use, and particularly the conversations have been with respect to youth. One thing that we do here, we hear a lot from advocates who oppose that initiative are around creating worsening barriers and stigma for people in accessing services or healthcare if they experience, if they do become certified under the Mental Health Act. And again, the unintended consequences of not having someone present to care again in the future, should they have a traumatizing experience, if they, as not having right to choose. So that's just a touch into the debate. And it definitely involves the expertise of psychiatry as well as concurrent disorders. It's a really challenging area.
Third question, and I don't know the name of this film, but in the early 70s, there was a film that suggested that everybody over 30 be put in not really a camp, it's like a retreat. So it was they retired people from the population into an area that they could do whatever they wanted as long as they didn't affect the rest of the society, which happened to be under. So I'm interested to know from people who are participants, who are using, their thoughts on do they feel marginalized by being given the drugs, or do they try to continue their addiction, or do they feel empowered, or do they feel that this is an avenue to a different life?
Yeah. So like through prescribing pharmaceutical alternatives, how is that received by patients or people with experience with substance use? Yeah. So that's like a limitation of this specific research, is that because of when the work happened, ideally we would have engaged all people accessing, like engaged in the service delivery. So we were only able to take the provider perspective, right? So as a prescriber or a program delivery person, the most important voice is the voice of people with experience who are interacting with the healthcare system or presenting to the healthcare system. And that's like a major area of work that needs to be done in terms of a research context and a limitation of this. I can speak anecdotally to my clinical experience, and anyone else in the room who has clinical experience, I welcome your comments, but generally at the individual patient level, people are, I would almost say when we started offering during the pandemic, we were one of the few clinics that really remained fully operational. The RAC, people would cry in shock that they were being offered an alternative opioid to what they were purchasing on the street. People were very, very concerned about imminent risk of death, and that risk going up even more with COVID restrictions. And they couldn't believe that that was something that was being discussed in a healthcare setting. And we did see people continuing to engage in our services who otherwise wouldn't present to care autonomously. So from the client perspective, I would generalize that it's been well received, because people often will say they need some degree of stability and security, housing, for example, other healthcare needs met before they can successfully address their addiction. And so being able to offer something that keeps people alive in the interim while we can support them through those other avenues that take longer is generally very well received. Does anyone else want to add to that? Okay. Any other questions or comments? Thanks for your time today.
It's too bad your research was done in COVID. I hope you're
Yeah.
non-COVID.